So today we'll start off with some part of prosthetics, maybe complete dentures, few chapters. What I will do is some part of theory we will cover. Every theory is important. You have to read from books. There is no shortcuts. Shortcuts, reading notes like books will not give us knowledge. You have to read from textbooks. I think they might not know what is the difference between a textbook and a notes. You know the difference? You know any textbook for prosthetics? Phillips, yes. Anusavis is a book for dental materials. Then you have crossed first year and second year, so at least some books for prosthetics you will know. Any books for prosthetics? Finna, Fenna. Fen. Finn is a pedo book. McDonald and Finn is pedo book. Fen. Okay, then you've read Fen. Voucher. Then you tell me some names for prosto books. Deepak Nalusamy, Rangarajan. That's all. Schillenberg. So there is some difference. Reading from books like what you said, it's not wrong. They have compiled, they have put in a lot of effort and compiled and brought in that book. So what we have to do is only towards an exam when we don't have time, that kind of books will be required. Before that, we should also try to do what they have done. Read from the books, compile and make your own notes so that you will remember it for life. Whatever we are reading, and into dentistry, it's not that we are going to read and then finish the exam and go out of it. We are going to practice dentistry for our life. So something that we read should remain with us for our life means you have to also put in that effort to read from books. Books means like what you said, Boucher, Hartwell, Winkler. So these three are basics for your complete denture. For fixed partial denture, either Schillenberg or Rosenstiel. For removable partial denture, it is Stewart or McCracken. So these are more straightforward books. If you read Stewart, the whole part of RPD you can cover. If you read Schillenberg, almost whole part of FPD you can cover. So read from that books and then come to this book so that in your exam you should not leave out in your marks, because even I advise this for my students, but sometimes when you read from Hartwell and write the whole essay, you still leave some paragraphs. You still leave some methods which were included in that book. So you have to also read that, but before going to those notes like books, you have to read the textbooks. So this was taught to us not as a PG or because I am a teacher now I am telling. When we were in UG, we were taught like this. We had Boucher and Winkler definitely, Schillenberg and Stewart and McCracken, also Bernard Levin especially for impressions in complete dentures as a final year BDS student. So not only for prosthetics, for all the subjects, you try and read, go to the library and refer many textbooks and read for the enjoyment of the subject, not only for writing and passing the exam. Even if it is 2 days before the exam, enjoy the subject and read, you will remember it throughout. Okay, so with just that we'll start. So complete dentures, you will have to cover anatomical landmarks, impressions, jaw relations, articulators, selection of teeth and arrangement, concepts of occlusion, insertion and post-insertion sequelae. As much as possible, at least half of it we'll try to complete today. So first we'll start with maxillary anatomical landmarks. So what is a denture bearing area? Denture bearing area or denture foundation area is the surface of the oral structures that are available to support a denture. It will be definitely fast for maybe all three also except for you, because you would have already learned these. We, for intense coaching, we just brush up the theory so that we want to concentrate more on the MCQs. So whenever you want to stop, because it's not a very formal class, informal class of very few people. So if you want to stop me anywhere, if you want to know about something more, you can stop me. So basically always the denture bearing area will be divided into support areas or stress bearing areas, peripheral areas or limiting areas and relief areas. In both all these three, you can again divide it into macroscopic anatomy and microscopic anatomy. Stress bearing areas are areas where you can apply pressure. Limiting areas or peripheral areas are that is along the border of your denture, and relief areas are areas where you cannot apply pressure. So for that, first you should know what a complete denture is. No, complete denture is an artificial prosthesis which is going to replace all the teeth along with the supporting structures. So what is remaining for you from the patient is only the residual alveolar ridge, upper and lower residual alveolar ridge, on which you are going to construct a complete denture for the patient. Supporting structures includes the residual ridge. Residual ridge means that which remains after the tooth has been extracted. Facial slopes of the residual ridge, flat surfaces of the hard palate, rugae area and maxillary tuberosity. Of these, the main area which offers primary support is your flat areas of the hard palate and the posterolateral slopes of the residual alveolar ridge. These two are the primary stress bearing areas. Rest all will come under the crest of the residual alveolar ridge, rugae area and maxillary tuberosity will come under, even canine eminence sometimes will come under secondary stress bearing areas. So ultimate support is from the palatine process of maxilla and palatine bone. Ideally, to call an area a support area, it should satisfy some factors, like it should have keratinized mucosa, it should have good thickness of submucosa to act as a cushioning or resiliency, and then it should have compact bone. So wherever you are having these, you can call that area as a primary stress bearing area or a good support area. But unfortunately, most of the areas that is available for us to construct a complete denture do not fall under these areas. This criteria, that it has a compact bone also, it should have a thick submucosa, it should have keratinized mucosa. Not many areas are complying to this points. The residual ridge is what remains after the teeth is lost. The crest of the residual ridge is considered as a stress bearing area. What you have is a layer of dense fibrous connective tissue intervening between the mucosa and the underlying cancellous bone. Cancellous bone, sometimes it is a compact bone. What happens is the lamina dura that is around the tooth, no, that is a compact, made of compact bone, bundle bone you say, no, that's a compact bone. But what happens after the tooth is lost, that also starts getting resorbed and the cancellous bone part gets exposed to the outside. So the bone, the submucosa and the mucosa. That's the residual ridge and the facial slopes of the residual ridge. Only the posterolateral slopes is important for your support. Rest all the other slopes are not contributing towards support. Remaining facial slopes are not essential for denture support because they have more loosely attached mucous membrane and is non-keratinized. So the primary support area which you should not miss is the flat areas of the hard palate and the posterolateral slopes of the residual alveolar ridge. In the flat areas of the hard palate, anterolaterally you will see adipose tissue and posterolaterally you will have glandular tissue. In cross section, first year also you have learnt the landmarks. The same landmarks you will learn in your second year, as in your final year and after you finish your internship also. There should be some difference and some more details into it which you have to learn. Initially you will just learn that it is the rest of the hard palate. This is the hard palate, this is the alveolar notch. But as you come to final year, you should also learn why that area becomes important, why that area is a stress bearing area, why it is a relief area, something more about the histology. So anterolaterally these things can be asked as an MCQ question also. Anterolaterally it has adipose tissue, posterolaterally it has glandular tissue. If you have any confusion in this, if you see the choices will become confused, you can remember A and A. Anterolaterally it is adipose. So in the histology, anterolaterally you see adipose tissue, compact bone, posterolaterally it is glandular. Those areas are the flat areas of the hard palate. Underlying bone is compact. You have the functioning tensa veli palatini and levator veli palatini muscles of soft palate which provide some amount of tension. There are areas like in your both in the maxilla and the mandible, wherever you have muscle attachments, those areas will not resorb easily. So it will act as an area of tension according to the pressure tension concept. Wherever you have pressure it will resorb, wherever you have tension it will not resorb. So areas where you have muscle attachments, those areas will not resorb that easily. So coming to the arch form of the palate, the arch form can be either square, tapering or ovoid. Square will offer the best retention and stability. So what is retention, what is stability? So retention against gravitational forces. So when you are inserting a denture, it should not fall down. In your eye, especially with your upper denture, it should not fall down to gravity. So against your path of insertion, you should have some resistance. What is stability? Ability of the processes to withstand lateral or horizontal displacing forces is stability. What is support? It is the ability of the processes to resist forces acting towards the ridges, towards the path of insertion. Away from the path is retention, towards the path of insertion is support. Stability is horizontal. So ovoid arches are slightly less favorable than the square type of arches. Tapering ones are least favorable. So rugae, you know what are rugae? Rugae are the irregularly shaped folds in the anterior part of the palate. These are secondary stress bearing areas. Tuberosity again is a secondary stress bearing area. When it becomes a problem is when you have an undercut, when you have bulbous tuberosities on both sides. Unilateral bulbous tuberosity, it can be adjusted with your denture by changing the path of insertion. You can rotate the denture and insert it inside. But when you have bilateral severe undercuts in the tuberosities, then it has to be surgical. At least one side has to be surgically corrected before you make your processes. Severe bony undercuts on either side, then it has to be surgically corrected. On one side can be managed with your dentures. So next is the relief area. Relief area, three definitions are there to be called as a relief area. First is areas which cannot be subjected to functional pressure. Example is your ridge crests. Second is area where you have thin mucosa over the hard cortical bone. The amount of submucosa is relatively very less or even absent. Example for that area is mid-palatine raphe and tori. Third are areas where you have neuromuscular bundles passing through, nerves and vessels passing through. So incisive papilla is an area like that. Some ridge crest it is written in maxilla. Mandible, whereas in mandible most of the ridge crest will become a relief area. In maxilla most of the ridge crest is a support area, sometimes only it is a relief area. Mid-palatine raphe, tori and incisive papilla are relief areas in the maxilla. Mid-palatine raphe marks the junction of the palatine process of maxilla. It is covered with a very thin layer of mucosa. Sometimes it might not have submucosa also, or a very thin layer of submucosa. Because of this reason only, you have to relieve the mid-palatine raphe area. So you can see between, before we had also projected some histologic pictures. In this you see the thickness of submucosa is very less. So torus palatinus, these are hard bony enlargements which can occur in almost in the center of the roof of the mouth. It occurs in 20% of population. Similarly here also you have very thin layer of mucosa, so it has to be relieved. How do you provide relief in a denture? So again and again we are saying these are stress bearing areas, you pressurize that area. These are relief areas, give relief. What does that mean? Spacer. So when you are making your impressions, you will give spacer in the relief areas, you will not give a spacer in the stress bearing area, so that you can directly apply pressure in the stress bearing area. You will not apply direct pressure on the relief areas. This is just for them, not for you. Some things might be too basic for you. So incisive papilla covers the incisive foramen, opening of the nasopalatine canal which carries the nasopalatine nerves and vessels. Somewhere areas where you have these neurovascular bundles passing through, if you apply pressure, the patient will have pain. So those areas have to be relieved. Incisive foramen is located on the median line at the lingual gingiva of anterior teeth. One more importance for incisive papilla is almost these areas, because you are having neurovascular bundles passing through, these will not resorb easily. So even if the crest of the ridge, if the residual alveolar ridge is going to resorb, the position of incisive papilla is almost going to be constant. That is the incisive papilla. So in the histologic picture, you can see the nasopalatine nerves and vessels passing through the nasopalatine canal, through the incisive foramen. So to combine, the flat areas of hard palate, posterolateral slopes of the hard palate are primary stress bearing areas. Secondary stress bearing areas are crest of the alveolar ridge, maxillary tuberosity and the rugae. So other slopes are not contributing towards support. Incisive papilla, mid-palatine raphe and some ridge crests are considered as relief areas. So limiting structure, so as the name indicates, limiting means it is along the border of your denture. So start it from the labial frenum, labial vestibule, buccal vestibule, hamular notch and posterior palatal seal area. So in the labial frenum, it is a single band of fibrous connective tissue. Thing is, it has no muscle attachments, only it is a fibrous connective tissue attachment. So opposite to this, when you are making an impression, in the impression it is seen as a labial notch. In the denture also it is seen as a labial notch. So corresponding area for the labial frenum is called as a labial notch in the tray, in the impression or in your denture. That's the area of labial frenum. Labial vestibule extends between the right and left buccal frenum. If the buccal frenum is absent, it is in the approximate area of first premolar. So major muscle in this area is orbicularis oris and the fibers runs horizontally. That's the area of labial vestibule between the labial frenum and the buccal frenum. If the buccal frenum is absent, it is the approximate area of first premolar. So whenever you have resorption of the ridges, the denture should compensate for the thickness of the sulcus also. So during border molding, you not only record the depth of the sulcus, you also record the width of the sulcus, width of the functional sulcus. So as resorption occurs, the ridge becomes smaller and smaller, the width of the sulcus becomes more and more, and you have to record that in your denture. Labial vestibule. Buccal frenum contains one or more bands. So corresponding to the buccal frenum area, you get buccal notch in your impression or in the denture. The major muscles in this area are buccinator, orbicularis oris and levator anguli oris. So here the levator anguli oris will act from below the frenum, orbicularis oris from front and buccinator from behind. So three muscles in the area of buccal frenum. You will have to give a wider V-shaped relief. In your denture they would have also said when you are trimming it, give a wider V-shaped relief for the buccal frenum. This is because you have to allow the movement of three muscles. Levator anguli oris just below the frenum attachment, orbicularis oris from front and buccinator from behind. That's the buccal frenum. So when it poses a difficulty for us is when it is attached towards the crest of the ridge, then it has to be repositioned, surgically repositioned, and then the denture should be made. So there is one more area along this, what we have to learn is modulus. What is modulus? You learned this name before? Yes. It is 8 muscles. It's a confluence of 8 muscles, a small hub of tissue which you can also feel just within your corner of the lip, a small prominence inside, a small prominence, that is modulus. It is the confluence of 8 muscles of the face. The 8 muscles are orbicularis oris, buccinator, caninus, zygomaticus major, quadratus labii superioris, risorius, mentalis and triangularis. So these things a little extra for your theory and can be asked also. Caninus is levator anguli oris, triangularis is depressor anguli oris, the other name. So why this modulus is important? So when it contracts, this is a confluence of 8 muscles. So whenever you are border molding or giving a denture, you should allow space for contraction of this modulus. So approximate area of the first premolar and the second premolar in the denture flange, if you see, a small depression will be created. That space is for the modulus. So that's the area where the 8 muscles of face confluence to form the modulus. So buccal vestibule, this extends from the buccal frenum, when the buccal frenum is absent, from the first premolar to the hamular notch. Mainly influenced by the modulus, buccinator muscle and distally by the coronoid process. Thickness of the distal end of the buccal flange must be adjusted to accommodate the coronoid process and masseter. So which each area you have some influencing anatomical structures or muscle coming in which you should remember. So in the buccal vestibule, it is mostly the modulus, buccinator and distally by the coronoid process and masseter. What is coronoid process? Can you tell? It is part of the mandible. Okay. Huh? So, which muscle attaches in the coronoid process? Temporalis. Fibers of temporalis it starts from the temporal bone to the coronoid process, running along up to coronoid process. It runs along the anterior border of the ramus completely, and it ends almost at the retromolar pad area. So up to that it will run. Fan shaped, big fan shaped muscle starting from the temporal bone condenses down to the coronoid process and the anterior portion of ramus. So it's an advantage that you start now, that anatomy is still fresh for you. You should not forget. Anatomy should be correlated with all this. So there's one more importance to this coronoid process. Usually we say that the labial frenum, labial vestibule, buccal frenum, buccal vestibule, you can mold. You can ask the patient to purse the lip, do U, E and all to record, but you can also record with your movements. But distobuccal flange cannot be recorded by us. You can only functionally mold it, give instructions to the patient so that you can functionally mold that distobuccal area of the flange. How do you record the distobuccal area? Lateral movements of the mandible. So as the patient moves the mandible left to right, the coronoid process will come and adapt to the distobuccal flange. That's how you record the width of the distobuccal flange. If that part is missed and the posterior palatal area recording is missed, then you will have problem with the retention of the upper denture. So normally when you have done your denture, it will stay. The patient opens the mouth, it will fall down. The patient starts speaking, it will fall down because you have not given space for the coronoid to come and adapt to your distobuccal flange. The buccal vestibule from the buccal frenum to the hamelar notch. Width is usually 2 to 3 millimeters. It can go up to 3 to 5 millimeters. So all the vestibular spaces, the submucosa is thick and you have loose areolar tissue. That's why it is movable. So lot of submucosa thickness you have in the vestibular spaces. So this is one more term for the distobuccal vestibular space, is otherwise called as coronomaxillary space, because this space is in between the maxillary tuberosity and the coronoid process. So it is called as coronomaxillary space. Otherwise, the other name for maxillary distobuccal vestibular space. These things might not be required, described by Swenson. It is the functional filling. Functional filling of space is important, what we described before. Not only the depth but also the width in this area. So these are the boundaries for coronomaxillary space, and the muscles influencing this space are buccinator, superior constrictor, pterygomandibular raphe, masseter and temporalis. What is pterygomandibular raphe? And then silence. Two muscles joined together to form this, no? What are the two muscles? So something should start from the, okay, you tell me next class. It's too basic. So this is the coronomaxillary space. It is in between the maxillary tuberosity and the coronoid process. These are the muscles. So now can you tell me what is pterygomandibular raphe? Formed by fibers of buccinator and what is that? Superior constrictor. It is between the buccinator and superior constrictor fibers. Those two fibers will form your pterygomandibular raphe. So fovea palatine, these are posterior part of the hard palate. You have two small openings which corresponds to the minor salivary glands opening. So where it is, it's confusion whether it is anterior to the anterior vibrating line, posterior, on the posterior palatal seal, it's a confusion. but when you in books, in Winkler, if you read, they say it is not a very consistent part, whether it is anterior or posterior. Hartwell says mostly it lies on the soft palate, posterior to the hard palate and soft palate junction. That means it is in the soft palate. But still we are not very sure about this fovea palatine position, and it is not a very reliable landmark for your posterior border. Mostly it lies posterior to the posterior palatal seal, but it is not always a rule. Because many questions can come from this, mostly they can ask, or definitely, something like that. So what is the significance is, if you are going to cover the fovea palatine, we have to think about the saliva coming from it, and it can displace the denture. So that is the area of fovea palatine. So hamular notch is also called as the pterygomaxillary notch because it is in between the pterygoid process and the pterygoid hamulus and the maxillary tuberosity. It is in between the maxillary tuberosity and the pterygoid hamulus. Pterygoid hamulus is part of which bone? Pterygoid hamulus is part of which bone? Sphenoid bone. Sphenoid. Pterygoid plates are part of sphenoid only, no? Medial pterygoid plate, lateral pterygoid plate, pterygoid hamulus, some muscle binds around this pterygoid hamulus, no? No. So this identifies the distal end of your denture. So this should be located when you are making your primary impression itself. So primary impression, what is important is you have to record all the details from the labial phenum until the hamular notch. So if you miss to record the hamular notch in your primary impression, it is very difficult to compensate that in your secondary impression, and naturally it is not there in your denture. Similarly, in the lower also, start from the labial phenum, record up to the end of the retromolar pad. So only if you record up to the retromolar pad, you will record the complete distolingual flange. Otherwise, the important area which is required for your retention is lost, distolingual flange and the distal end of your denture. So how you can locate it? You can use a blunt instrument, mouth mirror, or you can use a T-burnisher to run along the crest of the ridge where it dips, marks your hamular notch. The denture should end at the hamular notch. It should not extend beyond hamular notch, because in the hamular notch, if you give pressure, it has a lot of loose areolar tissue. You can apply pressure, the patient will not have pain. But beyond the hamular notch, the amount of submucosa is less. Directly it will rest on the bone. So if you are giving a overextended denture, in the review appointment, you can see a lot of redness in that area. That's because you have compressed the area beyond the hamular notch. The denture should end at the hamular notch. So this is the histology of the hamular notch: compact bone, fibers of tensor veli palatini muscle, loose areolar connective tissue and mucosa. So the last part in your limiting area in the upper is posterior palatal seal area. It is the area approximately at the junction of your hard palate and soft palate where you can apply pressure in order to aid in retention of the denture. The parts of the posterior palatal seal are post palatal seal area and the pterygomaxillary seal area. Significance is it prevents air passage, so important for your retention. Otherwise, you will have retention loss, and if you overextend, the patient can have gag. The parts are post palatal seal that extends from one tuberosity to the other, and the pterygomaxillary seal which extends in the area of your hamular notch. So this is the pterygomaxillary seal area, and this is the post palatal seal area. So you locate the posterior palatal seal area by marking two imaginary lines, which is the anterior vibrating line and the posterior vibrating line. Anterior vibrating line will correspond to the junction of hard palate and soft palate. The posterior vibrating line will correspond to the junction of slightly movable soft palate and the freely movable soft palate. So your posterior palatal seal, if any question is asked, is this entirely on the soft palate only, because the anterior vibrating line itself starts from the junction of hard and soft palate. Posterior vibrating line is at the junction of freely movable and slightly movable soft palate. So entirely the posterior palatal seal area is on the soft palate. So how you record the anterior vibrating line? You ask the patient to say ah in short vigorous bursts or by Valsalva maneuver. What is Valsalva maneuver? பண்ணது இல்லையா ரெக்கார்ட் பண்ணும்போது இப்போ கூட ட்ரை பண்ணி சொல்லும்போது யூ ஆஸ்க் த பேஷண்ட் டு க்ளோஸ் த நாஸ்ட்ரல்ஸ் அண்ட் ப்ளோ. டெஃபரெண்டாக அந்த மூமெண்ட் தெரியும். இஃப் posterior vibrating line, you ask the patient to just say unexaggerated manner. You will see the movement of the soft palate and you will mark the line with your eosine pencil. That's how you mark, no? You dip the eosine pencil into spirit and then mark, not into water. Water means that marking will spread. If you dip it in spirit, spirit will evaporate and the marking will be seen in the patient's mouth, which can be transferred into your impression later. Ask the patient to say unexaggerated manner and mark the posterior vibrating line. The next step is you ask the patient to close the nostrils and blow. You will see some amount of movement of the soft palate in front of this. That will mark your anterior vibrating line. Only thing is that some fear that it is difficult that we are not recording it, but if you start doing it in the patient, you will find it very easy. So anterior vibrating line is in the shape of a Cupid's bow. The posterior vibrating line is straight, whereas the anterior vibrating line dips in between, no? Why does it dip in between? What anatomical structure comes there? Previous. This is the posterior vibrating line, is almost straight. Anterior vibrating line dips in between to give this typical Cupid's bow shape. Why is this depression? For the phobia we don't give some bony structure because of which we are not able to extend. That is posterior nasal spine. Posterior nasal spine comes in that area, so you cannot extend your posterior seal on that. So how to locate it? You can mark it with your eosine pencil. Posterior vibrating line, it is the imaginary line at the junction of aponeurosis of tensa veli palatini muscle and the muscular portion of soft palate. So almost your posterior palatal seal area ends with this aponeurosis of tensa veli palatini. After that you have all the other muscles of soft palate. It is visualized by asking the patient to say in short bursts in a non-exaggerated manner. That's how you mark your posterior vibrating line. This is the anatomy. Submucosa is loose and contains lot of mucous glands in it. Skeletal muscles also come into it. So anterior part you see, you have anterior part of the soft palate, you have only fibers of palatine aponeurosis formed by expanded tendon of tensa palatini muscle. It is less movable. Posterior part you have all the other muscles. Your posterior palatal seal area almost ends with the anterior part of the soft palate. So vault form is what you see in the roof of the maxillary arch. You can section the cast to see this. The vault form can be square, tapering or gently curved. In other words, it can be U-shaped, V-shaped or gently curved or flat. This is a V-shaped arch, U-shaped arch and a flat or a gently curved arch. So U-shaped arch offers resistance both to vertical as well as lateral displacement. V-shaped arch will only offer lateral displacement, resistance to lateral displacement and no resistance to vertical displacement. Flat will offer resistance to vertical displacement and not towards lateral. So soft palate classification was given by M.M. House, classified into class 1, class 2 and class 3. Class 1 is the most favorable form, class 3 is the least favorable form. Class 1 you have a lot of area for the posterior palatal seal area and the soft palate almost it is flat. The movement of the soft palate is quite less, so you can slightly go wrong in locating the posterior palatal seal area in the class 1. It does not affect your retention of the denture because the immovable tissue almost extends to about 5 to 12 millimeters beyond the hard palate. Most favorable type of soft palate configuration. Class 2 is slightly more curved than the class 1, about 45 degrees. So the amount of extent to which you can extend your posterior palatal seal area is about 3 to 5 millimeters. In class 1 it is 5 to 12, class 2 it is 3 to 5 millimeters. So junction is slightly more acute than class 1, whereas class 3 is the most acute form. So here you can see that from the junction of hard palate and soft palate, the soft palate really turns acutely at an angle of about 70 degrees. So the width that is available for posterior palatal seal area is quite less. So here you should be really accurate and record your posterior palatal seal area correctly. To compensate for the width, maybe you can extend a little more in the depth. Mostly it accompanies the high palatal vault form or the V-shaped vault form. So this is the soft palate classification what you have in class 1, class 2 and class 3. You can also see that the soft palate hard palate junction is not a very distinct line. The soft palate keeps continuing through the hard palate for quite some area. So factors important are in your impression you should have it extended at least 1 to 2 millimeters beyond the expected denture border so that you locate your posterior vibrating line correctly. And you should not always leave it to the technician to mark the posterior palatal seal area. We should mark and give. Post dam is the other, because dam mari creates a seal there, they call it as a post dam area. Posterior palatal seal, other name is post dam. Previously used, but now we don't generally use the term as post dam. Something like a dam, it stops left. Clinical determination, this we have already seen how to mark your area of anterior vibrating line and posterior vibrating line. So how you can record the posterior palatal seal area? Some things which we think these might not be asked, the name, year, all these becomes important here. But no other way that you have to read and mug up these things, write, mug up these things. Because I still remember that question in our All India exam was on fluid wax. This type of fluid wax we have never read before that. It was there in Winkler, but after that we have never missed that page. Whenever I read that, I still remember that it was a question in All India for us. Conventional approach was given by Hardy and Kapoor, 1958. Fluid wax was given by Nelson. Arbitrary scraping by Boucher. Extended palatal technique, which we don't generally follow, was given by Silverman. It was Mark Applebaum who divided these techniques into conventional, fluid wax, arbitrary and extended palatal technique. Though all these things I have explained in detail, we'll just see whether we know what these things are. What is conventional approach? Conventional approach is what we have described till now. You locate the posterior vibrating line area, anterior vibrating line area, mark that in the patient. You transfer that to the impression and then to your cast. So the extent of the posterior palatal seal is correctly determined from the patient to the cast. But the depth is not determined exactly. You are going to scrape it after that. Whereas in fluid wax technique, the depth also will be correctly recorded. After you have made your final impression, you will add fluid wax in that area and apply pressure in the patient's mouth and record the extent as well as the width functionally. Very good method, but little technique sensitive. Arbitrary scraping is without anything you are going to scrape in the cast. Extended palatal technique is approximately you extend from the posterior palatal seal area about 8 millimeters, which we don't generally use. The same thing is described completely here, how you do it. So after you have located the area and transferred it into your cast, in the cast you will scrape. How much you will scrape? In the middle, because you have the posterior nasal spine, you will not scrape more than 0.5 to 1 millimeters. But whereas as you go away from the midline, you can scrape up to 1 to 1.5 millimeters. Again at the hamlar notch area, it will become 0.5 to 1 millimeter. This is fluid wax. Over the final impression material, you can use any of these Iowa, Adaptol wax, Correcta wax and HL physiologic paste. And then you add material until it touches the tissue. In wax, whenever it exhibits a glossy appearance, it means that it has touched the tissue. It is opposite to your green stick compound. In green stick compound, we say whenever it loses its gloss, that means it has touched the tissue. Whenever you are doing border molding with green stick compound, we say that if it is losing the gloss, it has touched the tissue. Whereas in wax, it is whenever it shows a glossy appearance, it has touched the tissue. So to what details you have to read for your entrances? Iowa wax means what color, it was developed by whom. If at all, if there is a year along with it, you have to read that also. Correcta wax number, because it's available in 4 numbers. Now after that, as a PG, we learned that it is available in 4 numbers. Number 1 is used for this, 2 for this, 3 for this, 4 for this. But as a UG, I never knew that correcta number 4 only was used for fluid wax technique. Orange by Applegate. HL physiologic paste, yellow white by Dr. Harkins. Adaptol green by Nathan G. Kay. But these things, for few things which we notice, we are writing it in the class, but other than that, there are so many number of things like this. So whenever you finish this topic, you go back and read the same topic again. So that next class when you come, you have some doubts, you want some explanations, you can of course ask. Any questions which you are not able to find answer, you tell us. Even if I don't know, I can somehow find and tell you. So this is how you add your fluid wax in layers, paint it on the posterior palatal seal area until it adapts. So of course it is a most physiologic technique, directly functionally you are recording to the patient, but disadvantage is handling the material is little difficult and time consuming. Arbitrary scraping is you leave it to the technician to scrape the cast. So what are the errors in recording posterior palatal seal? It can be 4. Either it is under extension, over post damming and under post damming. So under extension means in the width you have gone wrong. Post damming means in the depth you have gone wrong. So most common causes under extension, that is you don't extend it to the posterior vibrating line and reduce the denture before that. This can happen if you don't record it in your impression stage. If you don't record it in the impression stage and transfer it to the cast, when you are giving it for processing, it can happen that the technician will reduce the posterior palatal seal area. So overextension. This is slightly okay because if it's only overextended in the denture, you can check it in the patient and reduce it. Under extension means you will have to add up material and extend. That's a little difficult. Under post damming means the depth is less. So you will have air leak which can lead to loss of retention. Over post damming can lead to pain for the patient and redness in the area. Mainly it occurs in the hamular notch area. Finally, for the maxillary ridge, if you have abundant keratinized attached tissue, square shaped arch, palatal U shape in cross section, moderate vault, absence of undercuts, non-interfering frenum attachment and well defined hamular notch, you can call it as a ideal maxillary ridge. Similarly, we will start with mandibular. I will finish this impressions and then we will go to MCQs. The same way for the mandibular. So slightly different in form in the support areas and slightly some more new structures you will see in the mandible which you have not seen in maxilla. So as resorption occurs, what happens? Your maxilla becomes smaller and smaller, whereas mandible gets widened posteriorly so that you get almost like a class 3 kind of appearance, prognathic. So decide on an area for support. You have to know the quality of the bone, quality of the soft tissue, direction of forces and muscle attachment. These two we are adding up for the when you are talking about mandible. Direction of forces, whenever the forces fall perpendicular to the surface, those areas can withstand pressure better. So typical example is your buccal shelf area. Buccal shelf area where you have nice compact bone, you have muscle fibers passing through, buccinator passing through, so it will not resorb, and also the area is almost horizontal so that the forces that are falling on it is almost perpendicular to the surface. So this I already explained. Wherever you have pressure, the area will resorb easily. Tension areas will not resorb easily. So typical example is your area of mylohyoid ridge, where you have which muscle? Which muscle originates from mylohyoid ridge? Mylohyoid muscle. Sometimes you need not think so much, from the mylohyoid ridge, what else will come? Mylohyoid muscle only. From genial tubercle, where is genial tubercle? Lingual part of the mandible, anterior mandible. They are how many in number? 2 pairs in number. From the top pair, what starts? You have one muscle from the top pair, genioglossus from the top pair, and from the bottom pair, geniohyoid. And mental protuberance, you have mentalis muscle. So wherever you have muscle attachments, those areas will not resorb easily. So even in cases of severe resorption in patients, if you see, these areas will be almost on the surface of the ridge. Supporting areas, main support area is your buccal shelf area, which should not be missed in the lower. The second is retromolar pad. It is a support area. It is also a limiting structure. Distally, it is limited by the retromolar pad. And crest of the alveolar ridge. As I said, only when you have broad, wide crest of the ridge, you can call it as a stress bearing area. When it is knife edge, then it will become a relief area. So genial tubercle, mylohyoid ridge, mental foramen area are also bony areas, but if it gets exposed, then it has to be relieved. So it is generally a support area, but if there is more amount of resorption, it is getting exposed on the almost outside to the oral cavity, then it has to be relieved. So buccal shelf is the primary support area. It is bounded medially by the crest of the ridge, anteriorly by the buccal frenum, laterally by the external oblique ridge, and distally by the retromolar pad. The width ranges from 4 to 6 millimeters in width. It can be narrow also, 2 to 3 millimeters. So whatever area is available there should be recorded in your primary impression, so that you get support from that area. That is the area of buccal shelf, starting from the buccal frenum, retromolar pad, crest of the alveolar ridge, up to the external oblique ridge. So it has good cortical bone, right angles to the vertical occlusal forces. It has buccinator passing through. So that's why it is called as a primary stress bearing areas. So wherever you have muscles passing through, there is also a difficulty. Only when the fibers are running horizontally, you can cover the muscle. If the fibers are going to run vertically, then you will have to give space for contraction of the muscle. Otherwise, the denture will pop out of the mouth. So buccinator does not give a problem because it is a horizontally running muscle. You can cover that muscle. So histologically, again, you have thick submucosa with buccinator passing through, compact bone and horizontal supporting surface. Compact bone, buccinator muscle in the submucosa, thick mucosa. So crest of the residual alveolar ridge, whenever it is wide and broad, it is considered as a support area. Loosely attached, it has to be relieved. That is the crest of the residual alveolar ridge. But most cases, invariably, if you see, you all often see only a knife edge ridge, no? Not a very good well formed ridge. So you can also see the type of bone that is in the crest of the alveolar ridge. It is mostly cancellous or spongy. Again, as we had listed there, relief areas can be 3, which cannot accept your functional pressures. Most ridge crest. There we had written that it is some ridge crest in maxilla, whereas in mandible it is most ridge crest. Secondly, where you have thin mucosa directly over the cortical bone, it is mylohyoid ridge and tori. Third is when you have the neuromuscular bundles, mental foramen area. So mylohyoid ridge, it's quite low only, but as the resorption occurs, it raises up. In dentulous stage, it is almost here. As you lose the teeth, and when resorption occurs, it comes almost to the crest of the ridge. When it comes to the crest of the ridge, becomes prominent, then when you give pressure, the patient will have pain. That has to be relieved. So a case where the mylohyoid ridge, crest of the ridge and the buccinator are at the same level. You don't have any depth to cover in the lingual flange. Again, same as torus palatinus, torus mandibularis also, because the mucous membrane is thin, you have to relieve that area. Mental foramen area, it transmits mental nerves and blood vessels. Again, as resorption occurs, it will come to the crest of the ridge and it has to be relieved. Genial tubercle also is the same thing. There are some questions coming related to genial tubercle, whether you have to relieve it or not. Normally, we don't relieve the genial tubercle. You only cover the genial tubercle because it is going to be lingual to your lingually placed, not on the crest of the ridge. But as resorption occurs, if it comes on the crest of the ridge, if you want to not to cover the genial tubercle, then you will not have any space in your denture. The denture will break in the middle. There will be no width in the anterior part. So you will have to cover the genial tubercle, but underneath you have to give relief. So when the resorption occurs and genial tubercle comes to the crest of the ridge, there are cases where you see genial tubercle is even raised above the crest of the ridge. We see a lot of cases. Those cases you cannot exclude that. You will have to include that in your denture, but give relief from the undersurface of the denture. So these kind of cases we see regularly in the OP. See, normal position is here, but as the teeth is lost and as resorption occurs, it can come here, it can even raise above your crest of the ridge level, like this. The crest is here, but the genial tubercle is at this level. So again, your primary stress bearing area is the buccal shelf area and the retromolar pad area. Secondary stress bearing areas are the genial tubercle, mylohyoid ridge, metal foramen area and the crest of the alveolar ridge, which can also be listed under relief areas. Finally, limiting structures, same like your maxilla, you start with the labial frenum, labial vestibule, buccal vestibule, lingual frenum, lingual vestibule and retromolar pad. Retromolar pad is important for retention, stability or support. What is it important for? Retention. Only retention. For retention, for stability or for support. Final year. It's important for all three. Retention because you get your distal most seal from that area. It is important for support because it doesn't resorb easily, you can pressurize that area. It is important for stability. In which way? You mark the whole of the retromolar pad and you have learned from first year that your occlusal rim should extend only up to the 2/3 of the retromolar pad. The record base should extend only up to the 2/3 of the retromolar pad, never on to the posterior 1/3. Why?